So first of all, I would like to thank my old friend David Malkin for this very kind invitation, and also Jennifer Frebourg, the president. So many thanks for this very kind invitation. And of course, it's a huge privilege to be here. And I think that one of the most exciting parts is to meet all the families. And even if we are seeing patients in our own countries, meeting families, meeting patients, meeting teams is a huge way of stimulating our motivations. And of course, the patients present here are our daily motivations. I would like to dedicate this talk, of course, to all the relatives who unfortunately pass away, because we have that in mind, but I would like to amplify our optimism. So what I would like to highlight also is that with our colleagues present here, Laurence Brugère and Olivier Caron, we are going to launch the creation of the French LFS Association, so in 5 months, so in September. So I hope that will be an additional stone of this international cooperation. So what I would like to do now is to give you some highlights of the results we got in our LFS French network by addressing two specific issues. And I would like to start first by what you know very well now, the Chomprey criteria, as you know, our group with others have secondly update the different criteria in order to cover the diversity of the representation of the LFS. And as you know, we have this familial representation characterized by at least 2 affected relatives, and we have to integrate the incomplete penetrance. It's the reason why we are asked to have 2 affected relatives presenting these typical LFS tumors. We can have also this multiple primary tumor presentation, which is strongly suggestive of LFS, especially the first tumors has been diagnosed before 46 years of age. We have rare tumors, and you know the emblematic tumors such as ACC, choroid plexus tumors, the rhabdomyosarcoma of this anaplastic subtype, and early breast cancer, very early breast cancer defined as 20 years before 20 years of age. What is remarkable is that if you are looking at the mutation detection rate that we observe in France, like in other countries, is extremely high, even independently of the familial history. If you are looking at the mutation detection rate of ACC, we have mostly 50%, 45%. In the choroid plexus tumors, we have 42%. And as Garrett even highlighted this morning, for early breast cancer before 31 years of age, you have a mutation detection rate of 6%. So the fact that, of course, the familial history is not mandatory is a very important evolution of perception of LFS, which addresses the question, of course, of de novo mutation, and especially today because, as you probably know, since 2009, beginning of what we can call the revolution of the next generation sequencing, we are aware of the underestimated mutability of the human genome. So it's an important message also for the family. Please don't reduce your life to the genotype. You are not mutants. I am also mutant. We are all mutants. Okay? And you have your life, of course. We have tons of variations. And don't reduce your life to the genotype. What is important is a phenotype. And it's not because you have a mutation that you are sick. You are not a Li-Fraumeni person. Of course, you are belonging to a Li-Fraumeni syndrome families. You have an increased risk, of course, but please don't reduce, especially for the kids. So maybe it's a conception from a guy working in an old country, but I think it's very important to consider the power of the words. So to come back to the question of the mutability of the human genome, we know now that we need to accumulate mutation, and as you probably know, we know that probably per generation we have at least 1.5 variation per exome, exome corresponding only to the tiny part of the genome, the coding part, 1.2. Now, this de novo mutation can occur either in the sperm on the site, so before the construct of the zygote, what we call prezygotic mutation, but we know, and you have already heard some important message, that this mutation can occur during the development corresponding to what we call post-zygotic mutation. So in order to address the contribution of these de novo mutations, what we decided to do in France was to start from our series. So at this time, when we published this study, so a couple of months ago, we start from more than 320 unrelated index cases from different LFS families, and we check after that the presence of absence of the mutation in the parents. And in fact, we could demonstrate that we had 40 real de novo mutations. So, of course, it's maybe shocking for the family, but in France, like in Brazil at least, maybe not the case in Canada and US, but we have to check the paternity. And of course, a microsatellite analysis confirmed the paternity. So we could consider that probably the fraction of LFS family corresponding to de novo mutation were probably at least 12%. What is extremely important, especially for geneticists, is that we observe no parental age effect, because in other autosomal dominant disease, usually the main risk factor is the age of the father, and we did not observe any difference between the age of the father when we observe de novo mutation versus the general population in France. Now, since we had no mutation in the parents, we wanted to be sure that the parents had no mutation even when they were embryos. So we decided to resequence using this very powerful technology, so massive sequencing. And when you are performing massive sequencing, you are able to sequence sometimes 1,000 times, and we check the absence of the mutation in the parents. So I think that one important message is that at least we have 12% of de novo mutation contributing to LFS. Now, the second challenge was more tricky at the technical level, was to determine the fraction of what we call mosaic. And as you know, if the mosaic is occurring in a stem cell from which, the future tumor cell will develop, it will contribute to the cancer. But if the mutation is not in a stem cell from which blood will be generated, you will not see it, or very hardly detectable in the blood. So we had some evidence that in at least in some patients we have mosaics. For instance, we had this boy who developed a voluminous ACC at 4 months. And for people who are not familiar, when you are doing sequencing, regular sequencing, you sequence both allele, and you have 4 peaks corresponding to 4 bases. And if the sequence of the mother and the father are absolutely the same, you should have only 1 peak. If you have a mutant, you should have a 50% peaks, and the height of the wild type is similar to the mutant. And as you can see here, we have this tiny peak. And if you want to have a very quality check, you are not using that as a diagnostic tool. But we thought it's maybe not background, it might be a mutation located in only a fraction of the cell. And indeed, when we perform after NGS, we got this mutation in 17% of the reads, indicating that definitely these kid was a mosaic, that the mutation occurred when he was at the level of an embryo. So we had another example, which was probably most fascinating. We had a child with a Madeira Stoma, so you have the result here. Now, the child himself is not a mosaic. You have a perfect double peak here, so you have an heterozygote mutation. But when we look at the father, you can see this very tiny green peak, and the father was himself a mosaic, indicating that the mutation had occurred when the father was himself an embryo. And it's extremely important for geneticists because, of course, the risk for the father to transmit that to his daughter or his son is 50%. So we decided to do, because it was very tricky to detect that using classical methods based on single sequencing, to realize 108 patients strongly suggestive of LFS, but without detectable artificial mutation using conventional techniques. So we perform NGS at a high depth, above 500x. We analyzed 49 children with adrenocortical carcinoma, 21 with choroid plexus tumors, 31 females with very early breast cancer, and we found 2 mosaics here, 2 mosaics here, 1 mosaic here, 1 mosaic. So we detected 6 additional cases of mosaics that I will like to illustrate. For instance, we have this lady who developed a bilateral breast cancer. It was very hard to detect a mutation, of course, at a posteriori analysis, but of course we found a mosaic mutation. It was a bona fide mosaic mutation because the mutation was present in the tumor. We observed a loss of heterozygosity, so it was definitely a mosaic. And if you look this second example with an ACC at 8 months, we discover also a mosaic undetectable using Sanger sequencing. So just to summarize that, first evidence that we can detect it by classical methods that probably we had a high frequency of de novo mutations. We had evidence using Sanger sequencing that mosaic exists. Thanks to NGS, we were able to estimate the fraction of mosaic mutation, and taking message is that probably contribution of de novo TP53 mutation to LFS is at least 14%. 1/5 of the de novo mutation occur during embryonic development, and therefore, in clinical situation, very suggestive of germline TP53 mutation, we should perform genetic analysis using NGS at a high depth in order to detect mosaic alteration. Just to make the transition to the second part, I would like myself, like other investigators, to highlight the need to consider the penetrance of germline TP53 mutations, because we are all convinced that we have overestimated the penetrance corresponding to the cancer risk associated to germline, and which is a good message, of course, for the family present here. First, we have analyzed mostly very affected patients. We have a bias in our ascertainments. As I've highlighted, familial history is not mandatory. We have de novo mutation in only 14%, so you can inverse the bottle and consider that most of the germline mutation are transmitted. We know now that penetrance of germline is quite variable, and using the functional assays that we are developing in our teams, we know that we have a diversity. We know that the missense mutations are clinically and biologically more severe than the null mutations, thanks to functional assay. And you have heard very nice talks from different colleagues highlighting that the prevalence of pathogenic or potentially pathogenic in the general population was 0.2%, and notice that the same value observed using multi-gene panel testing, as Julie Garber highlighted in the nice lecture. So I think that we have overestimated probably the penetrance, and the message is that considering the medical and psychological impacts of TP53 mutation detection for the patient, because as you know, when we are delivering a positive result, we are going to change the life of a patient, of his and her family. We should be more and more careful as clinicians and geneticists with the penetrance of TP53 mutations. And maybe it's an old conception of genetics coming from an old country, but we claim that it's probably careful to restrict analysis to suggestive situation. Clinics first, patient first. So now I would like to move and to the second part corresponding to the question, the burning question of frequency of multiple primary tumors in LFS. We had published in the GCO that at least in our French cohorts, we had 43% of the patients who are going to develop multiple primary cancer. Remarkably, 30% of the patients who receive radiotherapy in the field develop secondary tumors within a radiation field. And we were very impressed by these case reports of patients harboring germline TP53 mutations who were free of tumor until 40, and after the first tumor, they sequentially developed multiple primary cancer. And of course, the hypothesis, which is, I think, very well known now, is that considering the key role, as David Lane in the seminal paper in the 80 claims that p53 is acting as a guardian of the genome, we could speculate that probably that DNA damage introduced by some chemo or radiotherapy could contribute indirectly to the development of secondary tumors. So what we decided to do was to address the question from the biological, and I would like to summarize 3 years of work. Some of the papers are not published yet. And we decide to analyze and to use, in fact, p53 as a universal sensor to DNA damage. Because as you know, when DNA damage occurs, all types of DNA damage, you are going to increase the quantity, the quality of p53, and p53 is going to act as a very powerful transcriptional factor able to induce the transcription of the gene. So what we decided to do was to develop a very simple, what we call genotoxic, universal genotoxic assay. The idea is very simple. You take lymphocytes that you are going to use as a tubes, and we are working on wild-type lymphocyte. You are going to expose the lymphocyte to chemical agent or physical agents that you want to test. And after that, you are going to the regulation of the transcription genes regulated by p53. So, because as soon as you have an activation of p53, you can claim that you have probably a DNA damage. So we perform first analysis at the transcriptome level. After that, we select what we call target genes. And after that, we develop a simple version of the assay. So the idea is to just quantify the level of induction of 6 target genes after exposure of wild-type p53 lymphocyte to the agents that you want to test. And you have here, for instance, the result. In blue here, you have the unexposed lymphocyte. In red, you have the exposed lymphocyte, and you are just looking at the height of the peaks, and you can define what we call a genotoxic score corresponding to the average of induction target or rate of selected target genes. And in order to demonstrate that you are considering only the p53 activation pathway, we are using, if you allow me the expression, the lymphocyte from patients harboring missense mutations as a negative control, because we know that the transcriptional response is compromised. So using this assay, we have first analyze the different chemotherapy used. So look first at the result here. So if you are looking sodium chloride as a negative control, you have 0.1. You have a genetic score of 1, which means that you have no induction, you have no genotoxicity. If you are using X-ray, of course, you have a huge induction score, and you see that the response is compromised in the LFS lymphocyte. And if you are analyzing now the different type of chemotherapy, you will think that anti-metabolic agents, alkylating agents, topoisomerase inhibitors, antibiotic agents are all, as we can predict, highly genotoxic, and the response, of course, is compromised. The only molecules commonly used in chemo are what we call the mitotic speedol poisons. They are efficient in some cases of cancer, but as you see, we cannot detect any genotoxic activity. So considering the importance of this result, we decide to go back, which is the inverse way that people are using, to go back to mice. So we developed the same assay in mice. We performed transcriptome analysis because the main target genes were not the same. So we did the same experiment. We took splenocytes, which correspond to the murine lymphocyte. And in fact, we did the same experiment. And after that, we did, in order to be more closer to the patient, what we call an in vivo assay, we took the mice, we inject the drugs, we submit to X-ray, and after that we sacrifice the animals and we analyze the different induction. And this table summarizes 1.5 years of work. You have here the result I already presented obtained in humans. You have here the genotoxic score observed in mice splenocyte exposed ex vivo, and you have here the genotoxic score obtained in exposed mice, exposed in vivo, and we have the same results. So the take-home message is the following, is that all chemotherapy, except mitotic speedol checkpoints, are genotoxic, not only in human cells, in mouse cells, and the good thing in the in vivo is that you could detect, of course, genotoxicity of some agents which are requiring metabolizations. So definitely there is a consensus. So just to finish that, we decide to develop a real mouse model. So all papers have already demonstrated that when you are considering murine models of LFS, you have evidence that radio could contribute to the development of secondary tumors. But we decided to restart that and to perform a huge study. So it took 2 years. So we analyzed more than 200 mice corresponding either to wild type or to, if you allow me the expression again, to murine model of LFS. And on purpose, we decided to use a deletion because, as you know, we can dichotomize the different germinal mutations in the missense mutation with transdominant activity and the other. I have only 40 seconds. And in fact, since the basic effect of all the germline mutations is the loss of function, we use the model. We adapt the Toronto protocol to the mice, performing monthly total body MRIs, and after that, autopsy. And the result is the following. So, of course, if you are looking at the impact of the chemotherapy, and we use etoposide as a paradigm of chemotherapy strongly genotoxic of X-ray. Here you have not a huge difference because we are dealing with minus mice who are strongly suspected to develop high frequency of tumors. But if you are looking at the clinical model of LFS, as you can see, either with etoposide or X-ray, as compared to sodium chloride of mitotic spindle, we observe a highly significant increased risk of tumor development, either in irradiated LFS model mice or in LFS model mice exposed to etoposide. So you have here the example of the huge development, for instance, detected by MRI of an LFS tumors in a mouse exposed and treated by etoposide. So the take-home message is the following. We had strong argument from the clinical part that probably we had a role of chemo and radiotherapy thanks to the sequential development of tumors. We had development of secondary tumors in the radiotherapy fields. We have shown, thanks to functional assays, that most chemo and radiotherapy have a genotoxic effect in functional assay. And we show here that accelerated tumors appears in LFS model exposed to chemo and radiotherapy. So we have evidence, like other investigators have already highlighted, that genotoxic chemotherapy and radiotherapy may contribute to the development of multiple primary tumors. So in order to reduce this risk, what is the conclusion? First, I think it's very important to be able to perform fast and accurate TP53 analysis in suggestive presentation, but before the treatment. So we should be able to do that sometimes in 5 working days to be helpful for the patient and the clinicians. And if we find mutations, of course, if it's possible, and only if it's possible, because the first priority is to treat the cancer, we should avoid radiotherapies, as the case, for instance, of breast cancer without metastatic nodes. We should prioritize surgical, and of course, we like to urge the community to develop non-genotoxic treatment and to evaluate using clinical trials. So I will stop here. Sorry, because I'm 2 minutes after the end of my talk. I will thank all these young people strongly involved in my teams. Laurence Brugger and Olivier Caron with us here. Stephen Friend, we amplified our structural optimistic. And of course, David Malkins, that's a picture. Sorry, that's David, I'm sorry. That's your very nice picture that we took last night when you try to explain the rules and what was a baseball game. So many thanks for your attention.